Tonight, we are honored to have two physicians with us who are going to introduce CalCare, which is we hope, our California Medicare for All bill. The first to speak will be Dr. David Leibowitz, and he will take us through some of the context, the background that brought us to today with CalCare. And we know David from earlier in his presentation to us on Medicare Advantage and ACO REACH. David is a hematologist-oncologist. He has practiced with Palo Alto Medical Foundation in a related clinic and referred to Stanford. He's recently retired and lives in San Mateo. Dr. Yusra Hussain will then follow him and talk about the specific CalCare bill, which was just introduced last week. And she is a currently practicing physician. She too is related to Stanford and is more in the general practice area. So we've got a specialist and a generalist. Over to David. David, I think you're muted.
Yes. Okay. I'm going to try to share my screen. So you will need to tell me if that works. It says screen sharing is disabled for participants.
Please try again.
Are you seeing a screen now?
Yes.
Okay. Let me get, are you seeing a slide?
Yes.
Okay, good. All right. So I'm going to tell you what the problems are, and Yusra is going to tell you how we can fix them. So this slide shows how much of our GDP goes to healthcare. It's comparing the United States to a group of similarly industrialized capitalist countries. And you can see that before the 80s, the US was kind of tracking with these other countries. But since the 80s, here's the US. And we're now spending about 18% of our GDP on healthcare. And that's about twice of what comparable countries are spending. This shows, you notice that the United States line is now on the bottom here. This is life expectancy. And it's again compared to a group of comparable countries. And again, you see that the change starts in the 1980s. This is comparing life expectancy in the US to life expectancy in Canada. In 1979, Canadians lived about 1 year longer than people in the US. Today, they live about 4.5 years longer. So we are paying more and having significantly worse outcomes. And the question is, why is that happening? And what we think the main explanation is an economic philosophy called neoliberalism. It's also called other things, market-based economy, trickle-down, supply side. The basic idea came from Milton Friedman and was championed by Ronald Reagan and Margaret Thatcher. And the idea was that markets would regulate themselves. If you had a free market, you wouldn't need significant taxes or regulation. And it's very interesting that in 1963, a Nobel Prize winning Stanford economist named Kenneth Arrow wrote a famous article about why healthcare cannot function as a free market. So it doesn't work. Today, already, most healthcare in the United States is paid with public funds. Medicare and Medicaid pay about a third. Other government programs pay about another third. The tax subsidies here are related to the Affordable Care Act. In the United States, our public funding is greater than the total funding in quite a few other nations. This is how much is spent here per person. And you can see that it's about twice as much as other comparable countries. So what's the finance model in these other countries? How do they deliver care? So they are all universal healthcare systems, and they are all not-for-profit. So universal, not-for-profit. Britain has the National Health Service. This is like the VA in the United States. The government owns the facilities and pays the providers. Canada has a national health insurance. This is pretty similar to Medicare in the United States. It's government insurance and private providers. Germany has what's called the Bismarck model. It's more complex, but it's still universal and costs a lot less than our healthcare does. The United States does not have a coherent system, and that's part of our problem. So here's the United Kingdom, covers everybody in the country, the government pays, and everyone is entitled to free care. Providers are employed by the government and are paid in a couple of different ways. And some people buy separate insurance so that they don't have to go through the waiting periods that are common in the National Health Service for some elective things. Canada has got national health insurance. This again covers everyone. The money comes from the federal government, and the federal government specifies what services have to be provided. Canada has an interesting system, though. The money goes to the provincial governments, and it's up to the provincial governments to decide how to implement the healthcare system. So the provinces have different systems, but they always provide both hospital and outpatient care. Providers are paid in different ways, but the ways resemble what happens in the United States. And quite a few people will have additional insurance to pay for things that are not included in national health insurance. The insurance doesn't duplicate the national insurance, but it provides for additional things. Germany has the original universal healthcare model. It was started by Otto von Bismarck in 1883 because he felt that if the workers were healthier, the country would do better. So there's an obligatory an obligatory insurance. It's called statutory health insurance. The money comes from the government. It comes from a tax on wages that's paid half by employees and half by the employers. That money is given to what are called sickness funds. These are the things that Bismarck had started. They are nonprofit, non-government plans. And the government sets the fees for the people who have the statutory health insurance. Some people buy private insurance that replaces the statutory insurance. So it's not in addition, it has to completely replace it. And these are often people who are younger and have higher incomes. This is looking again at how much we pay per person, and it divides the countries up by the type of payment system. So the top two systems are both single payer systems, and compared to the United States, they have the lowest cost. So it's the National Health Service or National Health Insurance. The Bismarck system is significantly less expensive than the United States, but it's a bit more than the single payer systems. And that's because it has multiple payers. There are a variety of different sickness funds, so the administrative costs are going to be higher. This is looking at life expectancy at birth, again, broken down by the different healthcare systems and different countries. It's actually pretty simple. All of the universal healthcare systems have life expectancies that are in the mid to low 80s, and the United States is in the mid to high 70s. So again, we're paying a lot more money, and the outcomes of the care are not good or not as good. Why is that? Well, so this slide shows the dark bars are the number of employees in the different countries, healthcare workers, and the red bars are the number of administrators in the different countries. What you can see is very nicely, in most of these countries, there are considerably more healthcare workers than there are administrators. It's different when you come to the United States. We've got almost one administrator per healthcare worker, and we're paying all of those people. This shows what has happened in terms of managers, administration in the United States over a 50-year period from 1970 to 2021. This red area represents managers. And starting in the 80s, the number of managers took off. And the increase now is 4,000%, which is considerably more than inflation. This little dark area at the bottom is the increase in physicians. These are two hospitals. Duke is a fantastic hospital. It has slightly less than 1,000 beds. It has over 1.5 billing clerks per bed. By contrast, the University of Toronto is also an excellent hospital. It's got almost 1,300 beds. That system only requires 7 billing clerks. It's obviously going to cost a lot more to pay 1,600 than it is to pay 7. How are we doing with the insurance plans we've got? Well, this looks at deductibles in private insurance. In 2006, about half of the plans had deductibles. Now, almost 90% of plans have deductibles. And what are those deductibles like? Well, they've gone up dramatically since 2006. And as all of us have experienced, deductibles as well as premiums continue to go up and are difficult for people to afford. And in the United States, the main cause of individual bankruptcy is medical debt. So we can choose one of a variety of systems. They are all nonprofit and they are all universal health care. Socialized medicine, what we think of as socialized medicine is what they have in Britain. It is the least expensive compared to the United States. A system that's essentially an improved Medicare for all is national health insurance, as they have in Canada. That's obviously still significantly less expensive than the US and has the same excellent results as the other universal healthcare systems. Germany, with the Bismarck system, is kind of unique because of the multiple payers and the increased administrative costs. It's not quite as less expensive compared to the US, but it's still significantly less expensive. And again, the United States really does not have a system, and it is the most expensive, and it has the poorest outcomes. So something is wrong. So the answer is going to be single-payer universal health care. It is a compelling argument. Academic studies have shown that the savings with this system would fund full coverage. Economists know this. The Congressional Budget Office has said universal coverage can be affordably achieved even as benefits are expanded and cost sharing all but eliminated. And if we see what doctors say, a doctor in Canada tells us it's not a big hassle. I can focus on patient issues, not administrative issues. And unfortunately, an American doctor tells us it's an incredible bureaucratic mess to get anything done for patients. So that's the background. Now, Yusra is going to tell you about an opportunity California has to fix this problem.
Thank you, David. I'm gonna, okay, when you stop sharing, I'll use my,
Yeah, that's
no
the-
problem. Take your time. I need to start my,
well, I'm looking for his. There we
It should
go.
be, do you find it? It should be at the top of the screen, David. I think there's a little red thing that you click.
Oh, yeah, I think I've got it. Did that get rid of it?
Yes,
Yep.
that did it. That did it.
Sorry about that.
no worries, perfect, actually. Okay, let me do this, and I'm gonna start view slideshow. Okay, here we go. So thank you all for having us here today. It's really an honor to be with you all, and just gonna actually set my time so that I don't go, because I know sometimes myself I can get carried away. All right, so before speaking about CalCare, I wanted to just bring you a real case of, some of the things that I deal with every single day. This is a patient of mine who's 91-year-old. She's actually very affluent. She lives in Palo Alto in a retirement community. She lives in the nursing care section because she's had strokes, and unfortunately she's bedbound. Recently, she's been having multiple issues with recurrent infections in her chest. And upon speaking with her family and her, she agreed to have a swallowing evaluation, which is essentially determining how safe she's able to swallow the food that she's offered. And if there are any certain techniques that we can provide her with that will make her safer. Putting in the referral, I get a call from her insurance that the only place she can actually have her swallowing evaluation is somewhere in San Mateo. Now, she is part of a Medicare Advantage plan, and unfortunately, even though she lives in a nursing facility that actually offers a speech and swallow therapist, and not only offer the evaluation, but offer also the subsequent therapy, and she only lives about 5 minutes from Stanford Hospital, which also offers the swallowing evaluation. Her insurance is only covers the place that's in San Mateo. So I called the insurance carrier and I requested prior authorization saying, maybe this is a bedbound lady that they will provide an exemption. Well, her insurance carrier told me they cannot do that and that she will have to go to San Mateo. And I explained to her that she actually lives in this facility and she could get the care here. And she said, well, why is she on this Medicare Advantage plan? If she wants to get the care at the facility, she should be on straight Medicare. And that's when I explained to her that some insurance broker convinced her and her husband that they are better off signing to a Medicare Advantage plan because there are better or more advantages being on that plan. And she simply just, ignored my comment and said, well, you better advise your patient to go on straight Medicare. That was the end of it. So that's just an example of actually a daily encounter that I have with insurance carriers, and this is an everyday thing. My goal today is essentially, and our goal, I should say, so to point to you what's wrong with our healthcare system, the profit-driven healthcare system, and then to explain what CalCare is and essentially how we can move forward. As you can see on this slide, that our California in general, there are 3.2 million Californians who are uninsured, and about 12 million Californians are underinsured. When we talk about underinsured, what does it mean? An underinsured person is a person who actually has some form of insurance, but cannot afford to pay for services that they need because the cost of out-of-pocket is too prohibitive for them to pursue essential care. As you can see here on the left is also a breakdown of the populations who tend to be most commonly uninsured. And unfortunately, Latinas and tend to be the highest. And as you expect, people who are below the poverty line as well. We have a healthcare system that is actually confusing and complicated. I'm not sure how many of you actually sat in November, December and tried to pick an insurance plan. I'm sure you all got frustrated with that. You have essentially multiple providers or payers, or payer systems. And then there are also these people who are uninsured. And then, so some of these are private insurance, which is the majority of people who are, 64 and younger, and essentially the publicly covered Medicare and Medicaid services will cover those who either who are 65 and older and have paid into the system, or those who have chronic illnesses that is generally, and they cannot afford healthcare. And then from there, you have different plans, do you want managed care? Do you want fee for service? And then each will have a different physicians, different hospitals, different pharmaceutical drug coverage. And it goes on and on, essentially, so how do you decide on what premium, what deductibles and what co-payments? And all of it has to also deal with, what's your family size, what's your medication that you take? I mean, the list goes on and on, trying to make the most out of, or make the most intelligent decisions out of these complicated plans that we have. And this slide again highlights, unfortunately, how much patients pay out of pocket for long-term care. Also, the cost of dental, hearing, and visions that people end up incurring as they get older. And then here we talk about, the narrow restrictive networks that, people are faced with every single day. Just like my patient who I, just talked about, who had to go to San Mateo to get her care there because her insurance does not cover, the care that's in her place. This is actually a daily recurrence. You could have a patient who goes to a hospital for a surgery that is actually a hospital that's within their network, but then only later to discover that the anesthesiologist, for example, who actually was present at the time of the surgery, is out of network, and now they are stuck with a bill that they have no choice but to pay. There was no consent on essentially for them to understand that there is going to be an out-of-pocket cost, or maybe the consent was actually buried somewhere in the millions of papers that they had to sign in before their surgeries. So this is this is a reality that we all face every single day. And then Dr. Leibowitz very well went over, how expensive our healthcare system, yet our premiums are rising every single day. Premiums and out-of-pocket expense. Now, most plans, we end up paying essentially close to about $6,000, $7,000 out of pocket before insurance kicks in to pay for the services that are needed. So our broken healthcare system is not universal. As you can see, many people are not covered at all, and many more are underinsured. It's confusing and complicated. It's incomplete, inadequate, and it's narrow, restrictive, and it's too expensive, as you have seen again from Dr. Leibowitz's presentation. On top of that, this slide just tells you, in the year of the pandemic, $6.6 billion was collected in profit for United Healthcare Group because of the shutdown that happened. And executives walked away with, millions of dollars in bonuses, essentially because of that. So not only people don't get the care, but also their healthcare insurance are essentially making profits and money out of that. So what is CalCare? On February 8th of this year, California Assembly Member Ash Kalra, along with or backed by the California Nurses Association, introduced the Assembly Bill AB 2200, which is the California Guaranteed Healthcare for All Act. Let me just give you a brief background about what California Nurse Associations are. They are actually a branch of the NNU, which is the National Nurse United, and they have been essentially on the ground since the beginning of the 20th century, essentially fighting for nurses, for safe practice places, safe environment, and various issues. And in the bill, which is it's called CalCare, provides essentially a framework for administering healthcare essentially to all Californians. We're going to go over the details of what that is. So the principles of CalCare. Essentially, it's a universal coverage. It provides coverage to all Californians, regardless of whether they are citizens or not citizens. It is a single public program, meaning we will not have multiple programs like Medi-Cal and Medicare and other entities. It will all be under one umbrella. The money will come in from the dollars that we currently pay for the federal government to administer Medicare, which actually some economists looked at that, and we can talk about that later in the question and answer because I want to be mindful of the time. But basically, we can afford it, and it is, as I said, it's a single program, simple to use, comprehensive benefits. We'll talk about those in a second. And the beauty of it, it provides a freedom to choose any doctor or provider. That patient of mine could go anywhere, could go to any doctor, could go to any hospital that she chooses to go to. Essentially, it's free at point of use. Again, studies have shown over and over that by providing free services for patients to go and see a doctor does not necessarily increase unnecessary visits. It's actually, people will have better care and improved outcome and less hospitalization and less emergency room, and hence overall less cost to the healthcare system. The beauty of CalCare also, it provides just transition. So what do we mean by that? Just Dr. David showed you earlier that, we have a huge administrative services currently operating in the insurance industry. These people will be offered different jobs because once you introduce a system like CalCare, there is going to be obviously a lot more people who will be insured and will need a huge healthcare force. So we can improve on our healthcare force by training some of these individuals to provide actual care rather than be obstructive to care and services. And then patient care will be provided based on patient's needs. Again, this was essentially will be based on evidence-based medicine, much like what Medicare currently provides. If there is justification for a service, they'll pay for it. So when we talk about comprehensive benefits, basically it covers doctors and hospital visits. It'll cover medications, prescriptions, dental, vision, hearing, and diagnostic labs and imaging, as well as long-term care. These are, even current Medicare doesn't provide these things, these services, but however, with Medicare Advantage plans, you may get those, but you are again limited, significantly by, through other aspects of the plans. Under CalCare, all of this will be covered. The nice thing about it also, the savings that will happen is essentially from curbing hospital profiteering. Currently, it's hospitals can charge whatever they want, and this is why our healthcare cost is escalating, because really there are no rules or regulations governing how much a hospital can charge or a prescription medication can cost. Whereas having the power of negotiation with hospitals, with drug manufacturers, the CalCare Governance Board will be able to bring in the cost of these entities, at least stop the rise, and hopefully will bring it down. Will limit on the executive compensations and bonuses. It will legally fully fund rural and safety net hospitals. I do remember actually just during the pandemic in 2020, one of the San Jose main hospitals, San Jose Regional Hospital, had to close their maternity ward because it was not profitable. This provided an amazing place for women to get their care, and women had no place in the San Jose area but to go outside the area to, further hospitals to get their care. This will prevent that from happening. It will provide a special budget for underserved communities by even building, healthcare facilities and hospitals if needed. So yeah, so in general, these are the highlights, and I don't want to dwell further. I think I pretty much reached my time, and we'll take any questions from you. Thank you.
Thank you so much. Are there any questions? We have a good minute left, I think. Thank you so much, David and Yusra.
I'm so sorry. I thought I could actually do it faster, but
No, well, you had help with David too. Ashley Evans.
I would just like to thank both of you for coming. I feel like this is quite a scoop since the bill was just introduced a week ago. So we're really thrilled to have you here to explain it to us. Where is the opposition to this bill coming from?
I can talk about that. Essentially, the bill honestly is supported, I would say, or this form of care is supported by about 70% of Californians in polls that were done. The problem is you have a huge profit-driven healthcare system that is, the insurance carriers, the insurance providers who are going to be the main opposition. They're going to actually try to smear it as being, it's a socialist system. It's a failing system because people will wait in lines to get to doctors. Well, believe it or not, this is happening today. People are not able to find doctors and are waiting in line, So if anything, actually, this system will provide broader coverage in terms of, hospitals and services, and will take the element of profit out of it. But, this is really, in my opinion, where the most opposition will come from, is from insurance providers and drug companies.
So we're over time now. So let's take April and John, and then that's all. Okay.
Okay, great. John, are you first?
I think April. April.
Yeah,
April.
sorry. My phone's
Thanks so much for the presentation. One thing that we're seeing on the coast side here where I live is we have a lot of essential workers who don't really make enough money to provide themselves decent health care, but then they make too much money to be able to afford the public healthcare system. So they're really just stuck. So we're all hopeful that with CalCare, that will no longer be a problem. Would you agree?
100%. Absolutely.
Thank you.
Yeah.
John, if you unmute, thanks. John, you're muted again. You were unmuted for a sec there.
Okay. I just admire both of you for your outstanding presentations and giving us such a background. I just wanted to point out, on a recent trip to Europe, I was in England and I had occasion to use the health system in England. And it turned out I went to the hospital, I saw a doctor, and the only cost that I had as a visitor was for the medication that I got, which was about $9. But it was fantastic. And I waited an hour for service, so it was great. And I'm so excited about this bill that's coming up. And we, of course, as Democrats, will be, I hope, 100% behind it.
We love to hear that. We really love to hear that. David.
Yes. Thank you so much.
Absolutely.
Thank you so much for
Thank
coming.
you for having us.